All right, greetings class. So today we're talking about chest and lungs assessments. I've got my partner here, is one of our mannequins here at CAMC Hospital, and so he's going to help me get through this. So, grab my paper over here. Assessment of the lungs and the thorax is basically going to start with inspection. So when I'm coming in and I'm having my chat with my patient, I might ask them things like, do you use oxygen at home? Interview questions also, things like current or past illnesses or injuries to those areas, any health history, family history, and if they use any sort of respiratory medications or devices at home such as CPAPs or BiPAPs, things of that nature. Are they having any shortness of breath right now? Any trouble with coughing? Are they smokers, vapors, using any recreational substances on the weekends? Right? And have they noticed any noticeable changes in their breathing? So that might be some of the sort of subjective material that I would ask them. And then once we get to the actual assessment portion, I'm going to first just let them know that I'm going to be looking at these areas, and we want to make sure that we're protecting the patient's dignity, and if they have curtains, we can close those. So I'm just looking, listening, looking for accessory muscle use in the upper areas of the chest and in the abdomen and the sides here. I'm also looking for symmetry, skin color, if there's any lesions on the areas of the chest, and we can also do check the diameter of the chest, the AP diameter, and what we would do is we'd have the patient kind of lean forward. He's a heavy guy, so I'm not going to, oh my gosh, he's really heavy. But the way you do that is the width of the chest should be about the length of 1/2 of the top of the chest here. So the width to the width, right? And so basically what you're doing there is looking for anything like barrel chest, which could be a complication of COPD as well. After we've inspected, also with the respiratory rate, we're looking to see if they're breathing fast or labored at all. We can do palpation, and we're looking for some subacute air, or which could be crackling under the skin that might signify a puncture or something, a puncture wound deep in there. We can also do percussion, and I'll be the first to tell you I'm not excellent at percussion, but I know that if you percuss over the intercostal space on either side, you should hear resonance, or it should sort of ring a little bit instead of, if it has dullness, then that's going to signify that there may be fluid, maybe or something like that in there. After we've percussed, we can do listening. If you remember back in when you first learned about listening to lung sounds, you have bronchial, bronchovesicular, and then vesicular in the bases. And so the first thing we'll listen for, and we go left to right, and this is for anterior and posterior, so you have to listen to both the front and the back. And we're going left to right, and it's sort of like an S-shaped pattern, right? So we start here, left side, and we're listening, and I just tell my patients to, every time you feel me move the stethoscope, go ahead and take another deep breath. That way I don't have to keep saying deep breath, right? So we start at the left, and we're going over and over, and then we go down one, and then we make our S pattern. So we're going S pattern. We're just listening to all of those spaces, and then we go down to this side and over, right? And we would repeat that on the back side as well. And we're listening for things like crackles, bronchi, wheezes, rails, any sort of things like that. And then we could also just have a normal finding of clear. It could be diminished, if we can't hear them very well. And the same thing, we're inspecting the backside for the crepitus, which is the subacute air, and we're also checking. We can check for expansion by placing your hands on the backside and ask them to take a deep breath. And as we see symmetric with our thumbs as they kind of go apart, That's what we're looking for. So if they were to take a deep breath like this, and we don't see this side expanding, then we know we have a problem there that we need to look forward. One of the other things that you can look for with respiratory issues, you notice the hands, and if they have any clubbing of the fingertips, that could be a sign of poor oxygenation. And then, as I said, with the subjective assessment, we're doing our interviews and things like that. One of the other problems we can find, dullness, could be atelectasis or fluid, maybe a pneumothorax in there. So those are the main things to look for, problems to assess for. And I think that pretty much covers it. Let me know if I've missed anything, and look forward to watching your videos. Thank you.